Huh? Huh?
Wonderful presentation, Dr. Hamid. So this was your thesis, if I'm not wrong. What fractures did you consider? Like if it is a PSM versus subcondylar?
We included all the mandatory.
And you talked about still, for how long did you put the patient on IMF?
Like in the patients we needed IMF, it was around 2 weeks, 1 to 2 weeks in patients who needed IMF.
My presentation, a study on the pattern and sequencing in fixation in panfacial fractures is a prospective study. As we all know, a lack of awareness in public about the safety measures regarding helmet and seatbelt and all, we get a lot of trauma cases, and among that 4 to 10% is about of panfacial fractures. And why the panfacial fractures is very difficult to treat, it is because of the complexity and communication of the fracture and inability to establish an occlusal plane and a reference plane. And to figure out to which protocol does it fall to. We have a lot of protocols in between. And aims and objectives of my study was to establish a definitive protocol for the reduction and fixation of fracture, and to by maintaining the 3 goals, that's the functional, aesthetic and anatomical concerns. We have involved the interdisciplinary approaches from because most of the panfacial fractures have to involve the other departments also, like in ENT, neurosurgery and ophthalmology too. And to evaluate the efficacy of the protocol, we have been deriving. So coming to the materials and methods, like in the 1 year which I have been doing the fellowship in my center, we took the case of like 8 patients till October 22. We have been doing ORF along with interdisciplinary interventions. The follow-up were done in 1 week, 3 weeks and 1 month post-op. So the modalities or evaluating factors were the clinical photographs. Sorry. So this was like the most of the we were computing the complications involved. So seeing the it is less compared to the 2 patients had paresthesia, that was also resolving, and local deformity, trismus and facial asymmetry was for 1 patient. Coming to the discussion part, usually in the panfacial fracture fixation, many concepts and protocols are maintained. One is of the Killian-Kay concentric circle concept, where we consider one outer circle or in the vice versa. The next concept is, as all we know, like from the bottom to top, inside out, or the top to bottom, outside in. If it's from the bottom to top, inside out method, first we have to go for the IMF, and we have to start from the down, symphysis, body, ramus and fixation, then to the condyle, parency. And come to top to bottom, outside in method, we start from the frontal side, orbital roof, frontal sinus, ZMC, FNOE, IMF, LIFO fracture, palatal fracture, condyle, and then come to the mandible downward part. So my concept is like this, not like what we do in our center. The concept is to make it as simple, to start from the stable segment and to the fix to the unstable segment to the stable segment. But considering the 3 dimensions into consideration, the transverse dimension, vertical and anteroposterior dimension. So the transverse dimension can be maintained. factors. We consider manual just because of the factor that manual is like you can horizontal dimension and we get the positive greater height for the vertical dimension and it has contact with the bachelor.
If you feel that 30 also is not going to narrow the posterior part rather than cut the posterior part. So just on medial and lateral sides just narrow it because that's how the floor is. So you want to just bend those parts down. I prefer to bend it because it gives a smoother edge and the bent part is away from the orbit so it doesn't bother. And that's quick to do.
And suppose when we are doing floor and medial wall is also fractured.
Right.
We have, so before placing the plate only we have to do the transcaricular.
Not necessarily. I could do it later on if needed. Sometimes there is such good exposure from the floor side itself going alongside the oblique and the medial wall is very nicely visible. And once I put a plate, everything looks good. I probably may not open the transclavicular. But if I find some issue with FTT, no, it cannot because that part is slightly posteriorly placed in order to accommodate the inferior oblique origin also.
Okay.
So once you put that in, the only thing is when you bend it at the exact angle you want, placing it becomes difficult. So many times you have to make an obtuse angle in order to place. And once you place it, you cannot again bend it unless you had a transcaricular. That's the reason why sometimes that incision may be needed.
Otherwise we can just take it, become loose and push it.
I think we are up time. The next session is 9, right? Yeah, we'll just go ahead with the questions.
So when you make a secondary orbital reconstruction in case of an orbital trauma,
Right.
when you're placing the plate or you're placing the DSIs, what are the chances or I would say that what are the risks for a frozen blow post secondary?
Okay, post-secondary repair, what is the risk of frozen blow? I don't think your surgery, but not really a frozen blow. That wouldn't happen just after your operation. It could be due to edema that the patient is not able to move it, but then even if you see slight movements, you know that the neurological component of it is fine and it's just going to improve as edema suffers.
Welcome everybody, very good morning. I now request Dr. Nitesh Hegde, PCI, to come and chair the session.
Good morning to all of you. We will start the first session. Now I invite Colonel Dr. Suresh Menon. He is the first speaker for the day.
This presentation of mine will focus on two specific entities, OKC and ameloblastoma, since these have hogged the maximum limelight in terms of controversies and changes in treatment strategies. Beginning with OKCs, a new dimension emerged with the landmark study by Stolinga as far as the origin of the epithelium was concerned. He showed that if indeed it was the dental lamina and its remnants, all OKCs found. Potential of OKC is well known, and the primary factors are the expression of the anti-apoptotic and proliferative markers like BCL2, P53 and PCL8. In addition to that, there is a strong P63 stage is concerned. Initially believed to be a cyst, it was termed a tumor for two specific reasons. One is the neoplastic tendency of epithelial budding and mitosis. Later on, it was reverted back to a cyst, primarily because neoplasms do not regress after a treatment, while OKCs were found to regress after conservative management. Plus the fact that there are the diagnosis is primarily histopathology. You have aids like protein estimation of the cystic content or exfoliative cytology smears, where the protein primary reasons for it, the most common being incomplete removal of the lining. In addition to that, you could have new cysts developing from satellite cysts or from the adjacent area. There are increased risk factors for recurrence too. It seems to occur more. Why? To preserve the bone structure in teeth associated with this pathology, since most of the patients are young, and I wouldn't want to be quite successful with the size of the cyst decreasing by over 50% within a year. In addition to that, the epithelia undergoes changes histologically and biologically, gets thickened, so easier to remove the next time you approach the cyst. Levels of interleukin-1.
And you see the changes actually. The case. See, this is the cases there where in fact actually the sphenoid sinus is needed. There's no cariboutis there available for us. So that's the sphenoid sinus. So if you have to know how to do this, blah blah, the sphenoid sinus engagement, other sphenoid sinus engagement. Of course, we go with the follow-ups also. This was the follow-up was there, and here I showed you actually by tapping the quality of the implant, the sound, but of course we can't do it here because no sound is present. And there's one more thing is that people always are jealous also, some 10 or 20 lectures will be there with the zygomatic implants. But if you have, see, just if you have just 1 millimeter of the nasal cortical, you don't need a zygomatic, you don't means you are doing a zygomatic implant, but it's like that if you have the anterior then bone, then you can counter the flexion. So I will show you actually. See, there's a nasal cortical is present. Nasal cortical, I engaged it. That's how, it's a very success story is there. Because of the design of the implant, we are having such a high prognosis is there. And that was the follow-up was there. And you see the tissue adaptation also. Then this is like a fibula, the fibula was there and it was this fibula, there was a non-union was there.
Time is up. Sorry.
Okay, sure.
Thank you.
Good morning, Dr. Professor Vitume Constantin. We will be speaking on anchorage of extraoral implants.
Yes, good morning everybody. I'm very happy to be here and I'm really thankful to organizing committee for having me here and giving me the opportunity to share with you my experiences with extraoral implantology. Of extraoral epistasis are the retention, and it could be mechanical in the past, of course, chemical with skin glue or adhesive, and of course with extraoral implants. And I used several types of extraoral implants during my career. Of course, I started with conventional two-stage implants, then I moved to BOI, buzzer or disc implants, and now I almost exclusively perform corticobasal implants. I will show you several cases with auricular, nasal, orbital defects, what I've done. Craniofacial defects that they can be congenital, post-traumatic, and of course after tumor recession. The majority of our cases are oncology cases. And after those gross surgeries, there are consequences which diminish quality of life for our patients, as well as functionally as aesthetically. And of course, however, surgical reconstruction is the method of choice, especially after gross surgical excision. And as we're maxillofacial, craniomaxillofacial surgery, we try to perform a reconstruction immediately after excision of the tumors. However,
I've taken 10 samples now, and we have more number of patients, and we will come to the final.
Yeah, giving them a placebo
Will work.
for the callus, did you have any histopathological report regarding this callus?
No, we are
No.
not.
You
may
did
not be
only
passed in the ethical
sonography.
committee. No, we cannot pass that in the ethical committee to open for the callus. It won't be passed in the ethical committee. But ultrasound provides a very good
scan
idea.
or something else which is
No.
more.
Ultrasound is very good for callus formation, as per the review. The study which I quoted, they have shown that it provides a better idea of the callus formation at all stages when they compared with the CT and MRI. And it was non-invasive, easy to do, and cheap also. And relatively, the strength was very good in that study. We use
The
ultrasound.
last thing you can do now with CT scan, you can after
Ultrasound, the radiologist in
after
this
six week you can do.
ma'am, actually the radiologist.
For the more confirmation. you can
But
do.
the study is telling that ultrasound is better than CT for callus assessment. It's like of the same strength, you can say, but I don't think radiologists should agree for that. Go for CT to assess the callus. We have a senior sir, he can comment.
We always use ultrasound to be detrimental to the development of the callus section. And really, I don't think anybody will use the CT to see a callus section. Because radiographic healing is between 6 weeks to 6 months. So,
Can study, because ideally animal study should be done, but to isolate which is helping. But we were thinking and discussing this part that ideally we won't be giving our patients also like take this protein. Or normal instructions to the patient will be take these things. Why not add this? All the gym people they are taking it. If we can, then it may be helpful and possibly it may help to reduce.
Good morning, everyone. Good morning, everyone. Products like unilateral technical plastic. Besides the medical radiology, like what we do here is about traumatic, congenital, habitual, and surgical. And comminuted leaf-out fracture associated with guttural fractures with guttural awareness, erosion of the nasal floor by development of this. So this study is to evaluate the repair of the persistent post-traumatic oral fistula by unilateral buttocks technique of arthroplasty. So retrospective study during the after the COVID period from over January 2019 to December 21. So all the patients were reported into our hospital with mid-face fractures and pan-facial fractures into the study. So informed the consent ethical committee obtained. So 11 ONF so with a critical size of 4.5 to 5 mm square interface of speech involving the functional X-ray concern. So internal examination has to be done.
Locular ameloblastoma on the posterior side, posterior aspect or the anterior aspect, as you see on your left hand side. The 3D is reconstruction. If you see, although we say more often that the cysts tend to grow in an anterior posterior direction, but we have seen cases wherein there is the keratocysts in the aspirates. There is a technique called as a cell block technique where you take this the aspirate, centrifuge it, make it into a cell block. Almost all pretty sure that it might be an OKC. So then we can plan our treatment accordingly. The diagnostic algorithm for odontogenic keratocyst, histologically aspiration, protein content is less than 4. Then if it is a large lesion, either as a part of decompression, you can go take an insert of the lesion, usually a scallop cortex and sclerotic borders. Nowadays, they say if at all there is an taking again this from Mark's textbook, we as surgeons, we should be knowing the pathology in a very, very better way so that we can, and radical enucleation and marsupiation still part forms to be a part of your conventional management. Aggressive management, enucleation, peripheral osteotomy with any of the adjuvant therapies like cryotherapy, cornea solution or 5-fluorouracil. Radical resections with margin, segmental resections and reconstruction forms the radical part of management of OKC. As Sir told, the conservative management, what does it do? It allows the cystic cavity for the space to fill with blood clot, which will eventually organize and form fractures and things like that. Decompression, yes, they say decompression is a better form of treating it conservatively, but in Indian scenario, because a lot of literature, when you see, it says about, it takes around 103 days to reduce it by 25%. So 50% around 270 days.
No, that means that we know everybody should know. One you tell me, then it will be only what they say. 40 keynote PPRs. We tell on rotation we should be given. This year you get, not necessarily next year you will get on preference. But other who has not got, we can answer. At least 5 to 7 keynote should be given for.
नीचे एक्टिविशन चला ना नीचे दिया चला अपने को ऐसे ऊपर ही रहना नीचे मत जाओ नीचे नहीं करना एक फोटो वीडियो जैसे नीचे हम आया था ना
outcome. Contouring of the mandible, contouring of the bone graft to match the mandible is a challenge, and that can be difficult for midline segmental or hemimandibular situations. So the best contouring can be done with the rib graft, which I'll share you in a minute. And midline is extremely difficult. It's a fibrous lesion resected and then put a rib graft which can contour the anterior rib. This is way back treated somewhere in 2004, where I was using a lot of non-vascular fibula, the contouring of the mandible, and that's the post-operative result and the well-healed scenario post-surgically of the patient appearance. So you can have a contouring related to the parasympathetic factor, which is segmental, things which cross midline and called the hemimandible. The biggest challenge when you're using a bone graft to get the angle of mandible, a proper angle. If you don't get a proper angle, you'll end up with having this free end of the fibula somewhere outside the glenoid fossa and with the quadrilateral side. If you do not get this transverse dimension proper, you have this flattening of the pterygomasseteric area, and that is certainly because of the inward placement of this in relation to the original mandibular bone. Vertical height of the bone graft is mandatory, as all reconstructions are basically implant driven. So we require a double barrel fibula. As you can see there, this is a vascularized double barrel fibula and a post-operative appearance in the scenario. If it is non-vascular fibula, this is a classical case of non-vascular fibula. This is extremely important, as you can have. If this segment is positioned upwards or cranially, you will have no space for putting any of the dentition, and it should be avoided naturally. The post-operative appearance may not be changed, but this is not the proper scenario for the dental replacement. This is a proper scenario for the dental replacement. Fixation devices make a lot of challenge, and they are basically also implant driven because you need to remove some of the fixation devices in the scenario. Continuous plate is difficult when you want to handle the implant scenario or the implant situations. So the best situation could be use segmental kind of resections and load of the hemimandible onto this area leads to the fracture of the mandible. We require either this kind of a plate, but I always prefer non-continuous plate so that they are easy for the manipulations as far as the implant placement is concerned. So segmental reconstruction would require basically single plate, which is
explain the laterally directed forces might displace inferomedially, and anteriorly directed forces might cause a telescopic fracture, and high energy posterior impacts can cause displace laterally. Most common projections advice is segmental vertex view, which gives clear view without overlaying structure. For Gillies method, it is simple, easy to perform, and without much complications, giving satisfactory results of arch reduction. So zygomatic arch fracture is attributed to the muscle compression and mechanical barrier in the process of mouth opening and closing, thus leading to the serious limitation in mouth opening. Thus it is necessary to even record the mouth opening preoperatively and postoperatively. One of the statistical study of 963 patients with maxillofacial fractures, it is found that they have the highest risk of serious risk of mouth limitation of mouth opening is found with cornoid fractures and arch fractures. So reduction usually should be performed within 1 to 2 weeks in adults and within 1 week in children to avoid malunion and further subsequent correction to the prostatitis. One of the main limitation in reduction is post-operative redepression. This happens periosteal bridge poses a significant risk for redepression. This periosteal bridge happens in case of with the arches displaced more laterally, and these have more risk of redepression. So for my study, I have taken 3
classifications and challenges in implantology in a very short notice, and I was wondering that in a span of 15 minutes, how can I cover so many complications and give justice to this topic. But I tried my best, and in next 15 minutes I try to do as many as possible. I am Dr. Atul. I am professor in oral maxillofacial surgery in MM Dental College, Malana, Ambala, which is a part of MM Deemed to be University. To start with, what is a complication? Complication is a problem or difficulty that makes situation harder to deal with. It is an unfavorable result of a disease, health condition or a treatment. Here we are talking about implants, and an anticipated problem that arises following and is a result of procedure, treatment or illness. Here we are talking about implants. So as Dr. Onkar ended up with, that your skill is very important and you should be knowing your limitations before planning any case, and that is the best way to avoid complications. Implantology is an ever-changing field, and the things are evolving, the demands of patients are evolving, and we need to know our limitations to avoid the complications to start with. Then prevention is always better than cure. Here I am not saying prevention not to place an implant, but to prevent the complications which can happen during the procedures, because believe me, prevention is much easier than to cure these complications. Everybody hates complications, that is for sure. But as I was given topic like this, it is not only complication, it is complications and challenges. And as a maxillofacial surgeon, we normally get these challenges. We get because nowadays general dentists, they are placing implants, and implantology is not the thing which is done by now only maxillofacial surgeons, prosthodontists or periodontists. General dentists are doing it very routinely, and very routinely they land up in complications. And mostly prosthetic complications are, though they are not easy to deal with, but dentists still think that they will be able to deal with. What they are frightened of is the surgical complications. And as a consultant maxillofacial surgeon, I also now get more cause of complications rather than getting an implant placed in a patient's mouth. And same way I think will be happening with you also. So for us, complication is a challenge, and we should take that challenge. Then again, we should also know our limitations. As a maxillofacial surgeons, we do surgical part very good, but we are not prosthodontic patient. The main aim is tooth. Patient has come here for tooth, not for the surgery. patient wants a replacement of the missing teeth. So we should be doing prosthetic driven implantology, not the surgical driven implantology. Really very difficult to do this. And what I have felt over the period of time is it is just sticking to basics which will help you in avoiding the complications. Just stick to basics. I have seen many times very senior implantologists become more confident and they'll end up in complications. So that is the main thing, that stick to basics. Whatever you have learned from the beginning, you should do that, and that is the best way to avoid complications. Over the period of time, there are many health scales, but this is the health scale which I considered my favorite, and to see the success, because how will you come to know that whether it is a complication or a successful case? So this is a health scale which tells about the satisfactory level of the implant. I will not. Implant is the first indication when the patient comes to you with a complaint. The pain is rarely a complaint. Most often it is the mobility. Patient says that something is mobile, and whenever you get a call from the patient, you always pray that it should be the abutment and not the implant itself, because these things become very challenging after that. And the best way to know is the informed consent from the patient. But the thing is that we are the specialists, we know everything about implants, so maybe in 5 minutes what we tell to the patient will not actually understand all the things in that way, and at the end of the day.
In condylar fractures. As we all know, condylar fractures are one of the most commonly seen fractures in case of mandible. They cause various dysfunctions that include neurotismus as well as malocclusion. Surgical treatment is noted one of the mainstays of the treatment in cases of condylar fractures. As we all know, objectives which are to assess the articular function post-operatively in terms of maximal interincisal opening and lateral movements along with the occlusion which we have achieved post-operatively. Along with this, clinically we have also assessed the injury to the facial nerve and formation of the salivary fistulas, time taken in both the groups, and to assess the degree of reduction radiographically, mediolateral deviation. This what we used two projections. One is the PAV projection using the CIAM, and the second is the lateral oblique projection using the CIAM. Inclusion criteria: patients above 18 years of age irrespective of sex, religion and socioeconomic status, patients who are medical with following presentations: difficulty in obtaining adequate occlusion or reduction using the close reduction method, displaced or dislocated condylar fractures, shortening of the ramus height associated with premature molar contact more than 5 millimeters, unilateral or bilateral condylar fractures associated with other fractures like parasymphysis, body fracture or angle fractures. Unilateral or bilateral condylar fractures where exclusion criteria: intracapsular fractures, medically compromised patients which were not fit for general anesthesia, and patients aged less than 18 years of age. So we took 6 patients, out of which 4 were male, 2 were females, and we use our retromandibular transparotid approach to the help of our open reduction. Then we assess those fractures with the help of our posterior anterior projection, slight tilting of the head towards the other side, and same projection.
Always a tug of war between conservative treatment and radical treatment. Coming to the radical treatment, taking example of the first case, if we could have treated it radically, one could have Crohn's. It get exposed intraorally or extraorally, or at times it get infected and make sinuses. Apart from it, moreover, whenever we do reconstruction with the recon plate, it always restores the contour, not the function. Other option would have been fibula, microvascular fibula flap, but it gives patient extraoral scar on the leg, neck, and at times there is hair growth in the intraoral skin tissue paddle, and at times this skin tissue paddle is so bulky that it creates prosthetic problems. Clinics of North America, again 2013, mandibular reconstruction has given 7 options for the mandibular reconstruction, including all the microvascular flaps, fibula, anterolateral thigh flap, but I didn't use this also. So what I used? Good morning, one and all. Myself, Dr. Sonal Priya Bhansali, Associate Professor from GDC Jaipur, introducing an innovative technique for mandibular reconstruction, given the name mandibulolingual cortical informed so as I. So I treated this case conservatively with my technique. Here we can see the lingual perforation, expansion of the buccal cortex and buccal there are many places there are buccal perforations. Coming to the axial and coronal section, there is marked expansion of the buccal plate, hardly, and this was the OPG. Here we can see the root resorption, multiseptate lesion, lingual perforation. I treated this case conservatively with enucleation, curettage, aggressive peripheral osteotomy, carbolic acid placement, and then open dressing with iodophone gauze. And this is the post-op OPG with the iodophone gauze. And this is how patient comes back the lower lip. This is a 3D CT after 1 year. We hardly have any buccal bone left here, but we have plenty of the lingual bone. And in the sagittal section, we have lot of lingual bone like Great Wall of China, but we don't have any buccal bone. So my idea or my plan was to use lingual bone to reconstruct the buccal plate. So we cut the lingual plate 5 to 10 millimeter of lingual plate. We fix it on the buccal side and we fill the defect with particulate graft in between.
But that's an option that you have. Sometimes you can also get an abnormally thin zygoma. This is reported in the literature in ectodermal dysplasia patients. But personally, I have not had this experience in zygomas. So when you have syndromic patients, again look for the volume of the zygoma. I'm sure some of you have faced this problem, overextending, beyond the, well, simply because you have to go 360 degrees to get the right emergence of your prosthetic platform. You go about 1 millimeter beyond, and sometimes 2-3 millimeters beyond, and that can be a nuisance. So, and it can produce long-standing chronic side. It completely deformed the head. Implant head is deformed, prosthetic platform deformed. What can you do? You are talked it about 100+ newtons. No way you can take it out, right? So this is why it's advantageous if you plan the implant position always as anticipating a future second zygoma implant. So the first zygoma implant is far. If it's a little too towards the outer cortex, you can fracture the zygoma also. And with abnormal trajectory of the implants into the infratemporal fossa, you can lead to fat penetration. Lateral orbital wall, you can have issues. And these are all being reported and leading to diplopia, where they have had go in and even sometimes from external approach and release these muscles. Buccal fat herniation, especially if you're going into the infratemporal fossa, is a nuisance. You overcome it by just putting some bone wax and pushing it through, and then you continue with the procedure. Poor stability can have long angled implant. You can see the challenges you'll get if you have restricted mouth opening, and if you have a lower arch which is dentulous or it's called a ceramic bridge. Newer solutions are using a contra-angle handpiece and shorter drills. So we can also use these contra-angle handpieces. But the problem with some of the older systems, the drills are still long. So you have a challenge there. So you have to combine the contra-angle handpiece with shorter drills. To theatre, and then doing an ostectomy, and then an all-on-4 becomes a zygoma suddenly because you don't have any more bone. So you can avoid all these problems with just basically good planning. All right? So plan prosthetically and you'll have less problems. Match selective situations, I just want to highlight one thing. Usually, of course, you try to put a quad zygoma, sometimes you cannot, you just get.
In Bangalore, I've been given this task of giving you a video presentation about lateral window technique for maxillary sinus augmentation. I have no affiliations or associations with any implant companies or bone graft companies, financially or otherwise. I'm just showing these products because of the quality of these products. When you look at this slide, when there is complete immunization of the maxillary sinus, you'll be wondering what are the treatment options which you have in your mind. You can think about what kind of prosthesis you want to deliver to this patient. Construction with 6 or 4 implants. Depends on what kind of implants you want to put. You want to put a shorter implant or a parallel implant or a tapered implant. It all depends upon how you want to orient these implants. You want to place these implants parallelly. You want to add bone, you want to remove bone. So many things will be playing in your mind when you see a scan of this nature. And depending upon your competence, depending upon your constraints, and depending on what you want to deliver to the patient, you can either put a short implant there, in this case, or you can put a. So these are all the options you have, and in this case, even though the sinus is completely pneumatized, this doctor has placed the implant by indirect sinus lift, and you see where the implant has lodged itself. So you need to give a correct treatment plan for the kind of situation you are facing. So when you've got such wealth of knowledge about grafting and being a maxillofacial surgeon, what is stopping you from doing lateral window technique? That's why I asked you, why hesitate, regenerate? So this should be the main focus, and I'm going to tell you some tips and tricks so that you can all go back to your offices on Monday and start the direct sinus lift. Before that, you need to understand the anatomy of the maxillary sinus, of all the sinuses in the head and neck area. Maxillary sinus being the largest and the first to be formed immunologically, and it is lined by. I think it's better off not to do a direct sinus lift because you're causing more problems to this patient. So he's better off undergoing a functional endoscopic sinus surgeries, and then subsequently patient smoking history and diabetic status. If you violate all that, you'll end up with this kind of catastrophe, and all your graft will come out in the mouth. So be very wary of the anatomy, the anatomical landmarks, what you see, and then the grafting materials, what you're using, and with the armamentarium, you can start the procedure. Now, before doing direct sinus lift, you should understand the kind of anatomy which you can encounter. You can have a tapered, narrowed floor, you can have a narrowed floor, you can have a ovoid or squarish, and the most difficult part is the one which you have septa. Now, you should also be aware of all the armamentarium which you need to use, you should have while doing a lateral sinus lift. Now, you need to have these trephines, you can have these abrasive drill bits, a blunt curettes and a sharp curettes, whatever it is one. Now, this is one technique called thin out technique, where you can use an abrasive and just run it across, up and down. You can create an indentation after raising a thick mucoperiosteal flap. And then this clinically you can get this kind of a situation that you can thin out the wall and you can see beautiful slider membrane looking at you. And then you can also move the abrasive medially, laterally to enlarge the osteotomy depending on where you need to graft. And this is a trephine technique called wall-off technique, where you can use a trephine, punch there, you can get a small window there created, keep it in saline, and once you complete the procedure, you can always place that wall back. This is another technique where you can access the lateral window. Now, my favorite is always piezo. You can always use a piezo to create a lateral window. The chance of rupture of the Snyder membrane is very less or negligible, so this is my favorite of all the techniques which I've shown. Once the lateral window is created, you can use a blunt instrument or you can use a curette and go at the expense of the bone, and then raise the flap, and then you can always do a Valsalva maneuver to see there's no perforation. If at all there was perforation, you will have blood splattering into the site. So,
visual outcome of pediatric ocular injuries in patients with maxillofacial trauma, and also determine the types of etiological factors contributing to ocular injuries. I just want to remind everyone that here the etiological factors were mostly concentrated for orbital trauma, not for other maxillofacial. Now, coming to the material and methods, prospective study, this over a period of almost 2 to 3 years, around 100 children less than 18 years of age were considered. and all had ocular trauma along with maxillofacial fractures and non-specific. And uncooperative children were excluded from this study. Now, what we have used is, we have used Piramisi et al. Classification was adopted for this study. Now, visual acuity, age, sex, time, and periods of injury, the most basic. Intraocular foreign bodies, vitreous hemorrhage, edema, and retinal detachment. And concurrent facial injuries, soft and hard tissue were also examined. Now, as usual, and most common, it is like ultrasonography, orbital X-rays, 3D CT scan were also done depending on the case. Now, coming to the ophthalmological part, around 57 patients were managed conservatively for closed globe injuries, lid edema, emesis, subconjunctival hemorrhage, corneal liberation, uveitis, and 43 patients were treated surgically for tear of the lid, conjunctiva, cornea subluxation, and dislocation of the lens. And all concurrent maxillofacial injuries or fractures were treated.
Classification, they have included the cinematography along with tumors. The fibrous dysplasia can be countered without significant blood loss, and the cherubism, but cherubism is very vascular and may result in greater blood loss, so it may be occurs in an autosomal dominant pattern. The cementoossifying fibroma is now classified as a 2 neoplasm, but juvenile ossifying fibroma is classified under fibrous lesions. I would like to acknowledge these people for their contributions. I have one more new print left, so I would like to show 1 or 2 cases extra. There is an osteoma of the. Then another case where we couldn't get a specific diagnosis. The biopsy from the anterior ramus region showed anterior ramus of the manual, radial condition. But the non-curettage responded very well, and there was adequate bone formation, but we still don't have a diagnosis for this. The peripheral ossifying fibroma, something which should be differentiated from the cementoossifying fibroma. And finally, a case of eosinophilic granuloma. I just included it because it's also a kind of a non-eosinophilic.
Thank you, Dr. Gupta.
हाँ एक मिनट सर इधर थैंक यू इसका फोन आ गया यस उसका फोन आ गया यस यस Yes.
Dr. Sonal Priya Gonzala.
Yes.
Dr. Agnesh Pratap.
तुम्हारा क्या था यार? कॉम्प्लिकेशंस। अच्छा कॉम्प्लिकेशन वो ऐसा टॉपिक अगर सबसे पहले कॉम्प्लिकेशन पता हो ना तो सुबह अच्छे से काम करता है। नहीं कॉम्प्लिकेशन पता हो तो आप हाँ भागते भी हैं लेकिन अच्छे से भी काम करते हैं। तो यू शुड ऑलवेज नो।
We will be debating on the two, you can say, debatable topics in the implantology, that is the immediate loading or delayed loading, or ESI versus zygoma. So, in my view, debate is not to be win. Debate is just a way to respect or accept Professor Head, JLN Medical College and Hospital, Bhagalpur. Please welcome Dr. Richard. Second is Dr. Sonal ma'am, Sonal Mishra, Professor, ESIC Dental College, Rohini. Third, I would like to invite Dr. Divya Malhotra, Professor Head, Himachal Dental College. And then Dr. Karthik, Professor, SRKM, four of us, all four debaters of our debate. I am running fast because we have lot many things to discuss and we have limited time. I first invite Dr. Richard to speak on immediate loading. Dr. Richard.
Thank you so much, sir.
to speak in front of such esteemed speakers. My present heart rate is faster than when I run my marathons. So let me start with immediate loading. So this is immediate loading. We follow the triple guided concept like clinical evaluation, radiographic, CBCT, and the occlusal prosthetic part, and comfort. So then we decide which patient to take for the immediate loading. The first is a general physical examination. We avoid patients with parafunctional habits and patients with medical contraindications like patient on immunosuppressants or patient on chemoradiotherapies. So what we know, there's some problem in the I'll just continue, sir. So we go give it as a restoration or a progressive loading. When we do select a patient for immediate loading, the criteria for the bone selection would be D2, D3. If you plan for a full mass, it's always advisable to go 1 to 2 mm subcrestal for the better anchorage. There should be undersizing while preparation, and bone condensation is advised. These are the criteria to be followed. I'll skip. So the key for the immediate loading is when you place the implant, the minimum basic torque value should be 30 to 40 Newton meter, and the ISQ value should be greater than 65. That gives us an indication that yes, this is a patient where we can plan for the immediate loading. I'll start with the cases. This is a patient with perfect good occlusion, no parafunctional habits. Patient wanted for periodontal conditions. We remove the implant, or we remove the entire bridge. This is a case of immediate implant placement with immediate loading. We placed the implants, the torque value, ISQ value was perfect, and we loaded the implant there and then within a week's time. This is another case where the patient had been wearing RBD for a long time with impacted canine. The canine was removed, the graft was placed, but despite the placement of the graft, there was a lot of soft tissue defect, so we needed the help of the prosthodontist and we rebuilt it. Later, this is another case where the subcrestal implant placement was done, and because the right side occlusion was perfect, so we loaded the implant immediately within a week's time. Here, this is a collapsed posterior with missing anteriors. But yes, the patient got a good smile and temporary teeth to bite onto. Here, what I would advocate is early provisionalization. Even if you cannot load it to the occlusal level, at least the patient, this is around 75-year-old lady. She had a bridge, the bridge was removed, and a place to implants is not a proper placement, I would say, and gave temporaries because the aesthetic is very important, be a 30-year-old or 70-year-old person. Another posterior immediate bridge placement case. In any anterior, immediate implants preferably is any patient with missing anteriors would like to have immediate teeth. What I would suggest, what do I understand, is immediate or early loading is safe when the indication and the limits are respected. Thank you.
Thank you ma'am for keeping the time.
We'll first come to the historically it has been proposed that implants should be placed in a two-stage surgical protocol and then loaded and have an extended healing phase for successful osseointegration. And the main determinants of whether an implant can be loaded immediately or it has to be delayed loaded is the achievement of primary stability and lack of micro movements during the healing phase. Delayed loading selection, keeping in mind the medical status, osteoporosis, smoking habits and sufficient. Optimum site selected should be based on the restorative options primarily rather than the anatomical options that are available at that time. The implant morphology, design, length, etc. And in the case of full mouth, full arch restorations or fixed long appendages, we need cross-site stabilization or rigid arch, rigid splinting. Of course, the achievement of insertion torque values and ISQ values, some of the studies. So in conclusion, I can say that delayed loading is going to be preferred when we have low insertion torque value, because that will cause bone resorption if we are immediately loading them. Or if we have severe preoperative bony defects which require hard and soft tissue augmentation or distraction, especially in areas where the aesthetic demands are greater, for example, a high lip line or with multiple adjacent missing teeth. Extraction sockets of type 3, type 4 variety where the buccal bone is
left in situ. The wooden foreign bodies are particularly liable to fragment both on implantment and withdrawal, which makes the removal a particular challenge. They are soft and may harbor soil-borne bacteria, increasing the risk of infection even if a small fragment is left inside the wound. Those that penetrate the orbit must be removed completely in a controlled manner. The history of the patient did not reveal the presence of any foreign body. Radiograph findings were also inconclusive because of the moderate density of the wooden piece. The ophthalmic symptoms are due to the organic nature of the wood, which caused intense inflammatory reaction in the tissue tension. Coming to the conclusion, any penetrating injury to the organ, accurate history imaging are essential aids in diagnosing intraoperative foreign bodies. Further, the skill and the experience of the surgeon influences the prognosis and reduces the iatrogenic complications. These are the references.
Clear definition and classification of pan-facial fracture in the literature. Reconstruction should be approached as a puzzle, difficult to follow and establish pattern, sequencing and organization. Successful reconstruction can be achieved through a flexible approach and adheres to several key principles. A mode of fracture helps to identify the probable energy to impact as well as likely to extend the injury. Road traffic accident, interpersonal violence, sport-related accidents, fall from height, animal attack, and gunshot wounds. The surgeon's task is not only to ensure a complete anatomical aesthetics and functional repair of the face, but restoring to its original three-dimensional shape. The aim of presenting this case report is to analyze the principle that determine the choice of method of treatment and to prevent the development of secondary deformities. Here a case report, 125-year-old male patient met with a road traffic accident and admitted. On examination, no history of loss of consciousness, bleeding from the nose was present. Here, in investigation, the patient was subjected to hematological, biological and radiological investigations. Radiographic and three-dimensional CT scan image revealed bilateral fractures, bilateral angle, symphysis, E2. Patients underwent open reduction and internal fixation under general anesthesia. Through mandibular vestibular incision, right parasymphysis and right angle fractures were reduced and fixation achieved using mini plates. Thorough left submandibular incisions, left angle and left subcondylar fractures were reduced and fixation was done by using mini plates. After stabilization of mandibular fractures, maxillomandibular fixation was done. Next, maxillary buttress as mid plates, left buttress and left piriform and right geometric buttress.
You are on the operative floor is gone. Can I get your orbit, because I have questions for you. I was asking you earlier, so I have some orbits coming up. It's fine. I want to extract as much juice out of all of you as much as possible. So I should have. What are your thoughts instead of, because I told you that particular patient didn't have any bilateral flow in the life, you know. So what are your thoughts before I come back to Dr. Bansali? I mean, based on the thoughts which I vocalized there, you know, would you go for a scapula? Would it be enough for you to place some osteointegrated implants as those maxillary reconstructions for the last one?
I think if there is no option of the fibula, scapula is a good option with the scapular flap.
Sure.
You have muscle also, you can have soft tissue, you can get nice lining also, which probably is not possible with the fibular flap. But with the scapula, I think it is quite possible, and you can put implants into the scalp.
So that's what I was trying to replicate, saying it's, you know, a free flap reconstruction. Could you say any words on those?
As he says, the primary.
Have how much time do we have for the case for the orbit? Okay, this is when so one orbit extension here, you know, on the bottom picture which you see, the reconstruction wise, when the right maxilla is resected with ameloblastoma. So, what is your modality for getting that accurate orbital volume, and how do you stage it? I mean, from reconstruction to secondary procedures, fat grafting, you know, use choice of your implant. This is the thoughts I want to get.
Yes, yeah. So the ameloblastoma was posterior to the rim, was extending into the.
So I would prefer a two-piece reconstruction, which showing the presentation also.
Sure.
One piece is for the orbit and anterior maxilla.
Sure.
And the second is mesh. Adapted, pre-adapted, it would be better. Even I have done lot many intraoperative adaptations also for the cases. And you take a guide before this.
If you see from a long-term follow-up perspective, when we had this much before this titanium mesh, but entire thing, it goes back into one area like the orbital reconstruction that gives a benign pathologist or as well as for the trauma. The Hammer's key area, whether the defect is extending only to the anterior third of your orbital floor or is it extending? Because no matter the type of mesh what you're going to get, if at all it is going to the posterior third.
This is a disclaimer. Diagnostic implants are a good option whenever there is a perfect maxilla and there is no bone volume, maybe after oncological resections or defects after pathological resection or maybe age-related changes, because it gives us good volume of bone, good BIC, very strong cortical bone and multi-cortical anchorage and very good stability also, and the failure rate is very less. And whether it's routine atrophic maxillas or it is partial maxillectomy cases or it is a complete maxillectomy cases with fistulas, we handicap, or for the bigger fistulas, even we can go ahead with the implants and we can get the kind of implants for the lower denture like magnetic dentures, right? And we can handle all these kind of cases with zygomatic implants. Just a little bit note about the technique. You all know the classical technique is there, the modification of sinus slot and then extramedullary technique and this extended sinus technique. So nowadays we have these guided surgical techniques.
Dr. Richa ma'am. Dr. Karthik, sir.
I would now request Dr. Waqar sir to present.
Would like to introduce Dr. Paul Sambrook. Paul Sambrook, sir, is a professor in oral and maxillofacial surgery with a 32 years of experience. He is affiliated to the University of Adelaide. And RACDS Enzymes Meritorious Service Award, President's Award twice, and number of presentations, talk on transoral surgery in oral and maxillofacial surgery. I welcome you to the presentation.
Thank you very much for that very kind invitation, and thank you also to the organisers for the invitation to speak to you today. I have to acknowledge sincerely my co-workers in Adelaide, specifically Professor Surin Krishnan, who has driven the use of robotic surgery in Adelaide. Very close relationship. All three heads of units, in fact, were registrars together, trained together, and now we run the three units together. This comes after 3 decades of transoral surgery, particularly transoral laser surgery. We run a comprehensive head and neck consultative clinic in the Royal Adelaide Hospital and have done for 50 years. So we've nearly got our 50-year anniversary of running, as well as other specialists. All of these people up here are involved in both the ablative surgery as well as the reconstructive surgery, and we have members of all departments involved in microvascular reconstruction. So robotic surgery really was looked at. We had a robotic centre in Adelaide already, these sorts of procedures. The tongue drop procedures into the neck, or the lip split mandibulotomy, where oftentimes issues of post-operative radiation led to significant problems with osteoradionecrosis. So here's the history of the Da Vinci robot. As you all know, the Da Vinci surgical system, surgical cart, surgical console, and various vision apparatus that can be positioned anywhere around the theatre. So that's what drives the whole robotic arm. This takes quite a second. We'll set the patient up in this area to start, and then we'll move on, and a specialised assistant will sit in that position while the robotic surgery is continuing. So robotic surgery offers superior 3D images, stereoscopic vision, 75% better resolution than any previous imaging system that we had, and at a 12 times magnification. The robotic system allows tremor to be eliminated. So as you know, working at a 12 or a plus magnification, tremor can be a significant issue, particularly tremor with your eye, and surgeon. There are natural intuitive movements and good hand-eye alignment. The ability to work laterally and to the avoidance of repositioning of your scopes is a major issue with this. As I said previously, there's an assistant at the operating site to assist in some activities that are not robotically controlled, but also to provide any emergency input should that be required. And I don't need to go through that for this audience. So we've currently completed over 400 cases. You may think that some of these cases are not really were provided in order to get used to the system within the robot. but mainly it's used now for tongue-based tumours, for larger tongue tumour resections, and for pharyngeal wall tumours.
Yes, yes. You like them. If he's there, he can answer better.
Sir?
Yes, sir.
You told about the uses of the rubber straw. So we have to measure through the IOP or OPG?
So IOPA is going to give you even more clear detail than, so whichever tooth you need to have a closer vision. So I always prefer to take an IOPA. So IOPA will give you even more better detail than an OPG.
Thank you, sir.
Okay, just to add on to that, for the post-graduation assessment of the difficulty of your third molar surgery. Thank you. We'll invite the next speaker, Dr. Vishwaraj, and he's going to speak on at the end of 10 minutes that your time is over.
The food capital Indore. Myself, Dr. Vishwaraj Nikamo from Pune, is increasing day by day in all pathies. Prior, abdominal surgeries were like this or this, but nowadays no one wants to go inside. Everyone is asking, कितने टाके पड़ेंगे? दूरबीन से करोगे क्या? So demand of the stitchless surgery is increasing day by day. So I choose this topic. It's my own invention. At least 80-85% cases. You know all the management of impacted mandibular third molar incision, reflection of lap, osteotomy, suturing, then post-op suture removal and follow-up. MIP, MIT, minimal invasion. What is that? It has been awarded by the Government of India for this technique in 2019. And this is led by Dr. Christopher Himmele, Zurich, Switzerland. This is my clinic working round the clock.
Yeah, that's my queries, because when we have subjective assessment, probably bias and a lot of things
should have an
drop in.
Average of 30. So the papers give them evidence and.
We can do it as OSCEs, but if it
OSCE will be like a clinical exam,
but if
for the written part.
As a pure MCQ, we wouldn't know how much of critical review they are able to get of the literature.
No, clinical scenario based questions.
That we are doing it in a practical exam.
Okay. People are doing honorary job, like paper setting, people ask me. Conducting exam, people ask, is there any remuneration for conducting the exam? So, boss, you were all one of the center. So, what's the opinion? Like, people are doing it voluntarily right now. We are doing it voluntarily.
Once you put a tag, price tag onto it, then it is commercial business going on. It won't be the minds, it won't be the big minds who will be doing it.
Yes, sir. So what do you think, sir? I mean, there have been issues in Onco when I asked them to.
Travel is paid, sir. Travel is paid. Remuneration, even Rajiv Gandhi University is peanuts.
Yes.
So once we start paying those kind of peanuts, so it look like they pay for that university correction 60 rupees per paper.
Nothing,
No, 160 rupees per
Not
paper.
Rajiv Gandhi University.
Rajiv Gandhi, I have corrected and I have taken 160 rupees.
But it's still only 100 rupees more.
Able to appreciate the location of the bullet, which was right underneath the floor of the mouth. So retrieved in toto. Post-operatively, we applied a vacuum dressing to facilitate granulation, which helped in healing, followed by closure. Our fourth case was a 28-year-old female with history of gunshot injury to her face. Again, this was a penetrating type of injury. Through CT, we were able to trace the path of the bullet. As you can see, the bullet had fragmented into multiple pieces with the main So with the help of an endoscope, we were able to clear off all the other fragments. Thorough debridement was done, margins were refreshed, followed by closure.
Obviously, with the cavitation and secondary structures and because the vasculature living around it gets totally broken. Do you face anything like that? All your cases show.
So we had anticipated that in this case. So that is why we had applied a vacuum dressing to it. So that
action. You see, there is a once one you may to be the basic cystic lining and the infection, we remove it, and then we are dividing the total significant symptom with the maxillary sinus link. This is one of the other cases. It is a cystic lesion involving both the maxilla, and we are in the left side, we are cleaning the antral cavity. And one most important thing, when we are seeing the maxillary antrum through our digital endoscope, we first see the posterior and posterolateral wall. But it is very difficult to see the anterior wall with the conventional endoscope. So for that, some flexible endoscopes are there, but they are not routinely used. So we have to use the sometimes the 120-degree scope also, and to work with the anterior wall of the antrum. But this is a very difficult zone. And you see here is the concha bullosa formation. There is a middle turbinate. This is also this impeding the path. So we have to remove this middle turbinate with the face scissor, and then we look up to the normal. No other, what are the pathologies over there? Some cystic lesions are there. They will be punctured and cleaning it out over there. So the access is very much important. Your orientation is very much important, and you must know what are the other structures we are working on. So there requires the proper orientation of the instrument, of the scope with the maxillary sinus. So we clean it out. In another case, we have a patient having the severe problem with the maxillary sinusitis, recurrent sinusitis, and with the with severe infection and pus formation in the maxillary sinus. Otherwise, there is a formation of the in the upper process, so there is maybe CSF leak. So we are involving that to affect the cupriform plate. And first, again, we are using the backbiters to see the uncinectomy, and then with the two scissors. Then we going and find out again we are using the microdebrider in a second stage, not in the first stage. And then we have to go for the find out the natural ostium. When you find the natural ostium, you see there is a plenty of pus is coming out. When the plenty of pus is coming out, then we go through the proper access, and again we widen it out, clean it out thoroughly, and properly irrigate it, and make a proper middle meatal antrostomy. So ultimately, this is resolved with the further medication and proper nasal endoscopy, particularly for the maxillary sinus and this related disease. So we have to, when as well as working with the outside of the maxillary sinus, we look through the inside also, because otherwise finally the disease-free survival or disease-free state is not happen. So we have to see, we have to orient it. This is the basic instrumentation, the basic skill, and for that we have to take some amount of hands-on training for that, and let the knowledge is like the water, we have let it flow. Whether we should have a proper bath with it or we have to drink it for our assimilation, it is very important. And always Dr. Soumitra Ghosh is the ENT surgeon. We are doing the cases as a team, and I am in the learning curve for this basic type of endoscopy. So hope that in future we will go for the more amount of cases. But the thing is that I request every of my maxillofacial colleagues to acquire this kind of knowledge and sensitivity towards this kind of procedure, because this gives a fantastic good results. Thank you all. Thank you for that. Actually, the thing is that about the hemostasis, sir is asking about the hemostasis. The main thing is that we have to use the adrenaline soaked gauze preoperatively. So there is some xylometazoline and
vision, his experiences. Sir is working in Army, Delhi.
One is my college senior and one is a good friend. So regards and greetings from the Indian Armed Forces Defence Branch. Head and neck reconstruction is one of the most dynamic fields in the maxillofacial area. There is so much of scope, so much of confusion. So adding on to the confusion today, I'll be talking about our experience in PSI, though we have not done too many cases, but our experience is not very bad. So before that, we just have a rapid go through the literature that when we were going through the history of jaw replacement, we saw that the literature rationally of reconstruction of mandible using different kind of materials, and the article just below is mandibular reconstruction following ablative tumor surgery and overview of treatment planning is one of the best articles I've ever read actually of that time. Now in the current perspectives and development of PSI, the world's first specific jaw implant was reported in Belgium, and it was done in 2012, where you can see the model which they have made. They have increased the surface area by giving dimples and undulating surfaces. They have also made, if you see on the top of the ridge, they have made a space for dental implants to be fitted. Now 2012, that was just theoretically correct. Then we had other people talking about using PSIs with biological bone, but didn't give too much of emphasis on the reconstruction part of the rehabilitation part. Then the next came as the feasibility of custom-made endoprosthesis in mandibular reconstruction, implant design, and this is one of the first articles to talk about FEA, finite element analysis, which is very important nowadays actually. Then came an article which was talking about the junction point, which we call as the fillet. It is written there, the junction point between the reconstructing part and the anterior part, that curvature part, which is supposed to be the Vietnam implant, a case report. Now coming to the Indian perspective, when we were going through the literature, we found that from Lucknow in the year 2019 there has been a publication using a 3D, and in the year 2022 from Guntur there has been a publication, and the third one which we could find out was our publication, in which we compared 3 designs of PSIs.
Adapted, and there is less interference in bone healing. So, a prospective comparative study aimed to evaluate 2 different fixation systems for treatment of symphysis and parasymphysis fractures of mandible was carried out. The aim as described, and the objectives, primary objective being to assess and analyze the clinical radiological outcome, and secondary objective was to evaluate and compare the pre-operative, post-operative complication rates. The study was conducted in a tertiary care hospital in Western Maharashtra in patients with symphysis and parasymphysis fractures of mandible from March 2019 to June 2020. Total of 42 patients were selected, and they were divided randomly but equally into 2 groups, Group A and Group B. In Group A, the treatment was done with mini plates, osteosynthesis, and in Group B, the osteosynthesis, the stabilization of fracture was carried out with a 3D blocking plate. Inclusion criteria was a clinical radiological diagnosis of the fractures, and additional fractures were also included of the mandible. The age was more than 18 years but less than 65 years of age. Exclusion criteria was previous history of lower face fractures, infected fractures, comminuted fractures, associated mid-face fractures, and others as described here. In the conduct of study, as said, 42 patients were selected, 21 in each group. A demographic radiological examination in terms of OPGs, CPCT and NCCT phase were done wherever required. These are photographs of the representative cases of Group A and Group B, the operative cases. The radiograph was taken to assess the fracture location, displacement and deviation of the fractures. All the patients were done under general anesthesia, and mandibular vestibular incision was carried out. And in cases of existing laceration, an extraoral incision was done. Dissection was done in layers to expose the fracture segments, and fixation in Group A was done as discussed. Was done with mini plate osteosynthesis, and in Group B by 3D locking plates.
The fractures increase difficulty of the surgery with age, and thereby more complications. And they also say that third molars have no definite role in the mouth. So I would like to conclude this by saying that numerous studies have been carried out on the third molars, but all of these studies have been subject to sample selection bias, subjective interpretation, or no clear-cut evidence. And thereby I emphasize on the need for well-designed prospective studies and long-term prospective studies so that this question finally is solved. These are my references. This is our school, D.Y. Patil Dental School, Pune. And this is my department and my staff members. So I thank all of you for a very patient listening.
Thank you very much, Dr. Vikram. I think we are already over. And thank you, speakers, for putting up a good show and sticking to time.
Request Dr. Vivekanand Kinjimani to come on the stage. This is a session which is...
So myself, Dr. Vivekanand Kinjimani, I am a professor in the Department of Oral Maxillofacial Surgery and head Department of Clinical Research. So I am happy to be here to share your thoughts. It's not my thoughts. Actually, when we started a topic on research, then why can't we go with the survey? I hope I am audible to you people. So we started a survey, and that survey results I am going to present here. So that's a. Then next comes the dentistry and oral maxillofacial surgery as a research. Many people may be thinking, what this guy is going to talk about 10 minutes. Definitely, it's very, very important because in everyday life, we are going to do a lot of research. Then what are the insights? Then we're going to talk about the barriers. Then we'll talk about the enablers also. Critical inquiry leading to the discovery of fact or information which increases our understanding of human health and disease, because as a doctor you'll be dealing every day with the health and disease. Definitely the research comes from various angles of everyday life, that may be a professional experience or it may be a practical issues like COVID mucormycosis, or it may be past research with the literature where you can find.
When he passes, we'll certify.
Definitely. No, it will be more of clinically oriented thing, whatever. Whom think Vijay?
XYZ promotes center by center as a fellow who does work with us for 1 year, learns half, learns full, learns nothing. If this is done a month in advance, you become a part of that ceremony.
There is a conference next year, no? Every year there is a conference, yeah. So if you for example fail in your university exam, they don't make another convocation for you. After you pass whichever is the next convocation, there is no need to worry too much about this year. Most of your, I have run fellowship for 12 years, nobody has failed. Because we don't fail them, simple. We make them work hard.
Yeah.
But if there is somebody who is not fulfilling the standard, this is just an eventuality.
At least at the back of the mind they should have, there is an evaluation process.
Yes. So more like
that's the basic.
But for trauma,
they come after their fellowship completes. Like today, who are collecting for orthopneutic has finished 3 months back.
Yeah. But in trauma,
what's happening on oncology? They've already got an exit exam, right?
They got an exit. They're very structured. The
Exactly.
theory is
Why
over.
don't we do that?
Viva. That's what we have discussed.
When you were not here,
that's what we have discussed.
So we will follow the same pattern, but we need to. So he's forming a small committee to decide on the specifics. Because I was interested in MCQ, he said he's doing subjective. So there are certain things to discuss. But it will be the circulate.
Yes. That will be circulated.
May not have all the directors sitting for all the candidates.
Which is there, it won't be there.
Bhagwan, it may be just a group every time.
इस कॉर्नर से बैनर पे आ जाएगा, पीछे लोग बैठे हुए भी आ जाएंगे और कॉर्नर पे बस 4-5 है।
Blood samples were centrifuged at 3000 RPM for 10 minutes and serum was separated. Centrifugation was done within 30 assist using ELISA kit. The outcomes was assessed on the basis of as primary infection and edema, and secondarily it was assessed as pain, nausea, vomiting and fracture healing. So these were the ELISA kits which were used for the study, and this was the centrifugation machine and procalcitonin test kit we can see. And this is the patients with different rates of edema, mild, moderate and severe, and with infection at the fracture site. Like gender, site and mode of injury and mean duration of presentation of injury, it was comparable in both the groups. So now coming to the comparison of edema in steroid and versus non-steroid group, and when we see the edema at 30 minutes of the after the trauma, we found that it was comparable in both the
This mostly account for 70.5 to 50% of the total mandibular fractures. The reasons being RTA, trauma, sports injuries, fall. Mechanism by which the condyle gets fractured is by direct blow to the chin, where the force is being transferred by the lateral blow to the chin. So the condylar fractures, they are just complicated by their intimate relation to the TMJ joint and the capsule. Now the direct fractures of the joint can cause the treatment, they can cause the prolonged immobilization of the patient, and which with the further complications after the treatment being malocclusion, internal derangement and callosis, and the reduced mandibular growth with facial asymmetry and residual pain as well. Now, symptomatically, these conditions which usually occur when we treat the condylar fractures mostly with closed reduction methods. Also, there are many classifications and many treatment options that are already available in the literature, that in what type of fracture which treatment is to be done. But in mostly cases, undisplaced cases and some by the surgeon's preference, they prefer the closed reduction as a treatment for condylar fractures. Coming to the aim and objective.
I had an up and down for all my cases, sometimes like any synthetic product, but yes, of course, something where we do tissue engineering and reconstructive scaffolds for maxillofacial reconstruction. I would like to start my presentation with this statement. A future in medicine is envisioned where medical treatment will become highly personalized, where we'll not have an implant which has been already custom made, prefabricated, stock made, and its patient has to adjust with that implant. But it is patient specific, where one fits to all approach will be denied later on. So, are we one step short, or all three surgeons, right, from maxillofacial, ENT and a plastic surgeon? But at the same time, it has drawn a maximum attention for the researchers to work on that direction and to get a new modalities to treat this complex entity of a maxillofacial region. As we see this case, we have a complex deformity. If you try to do it any kind of an operatively, so what is an option for those things? So if you look back in 1952 up to 1980s, the primary intention for reconstruction of such cases is to just make a disease free and leave it the patient. But after around 1980s onwards, with the advent of microvascular free flap, we started thinking of reforming, but function was not yet been a part of our decision. Later on, probably around 3-4 decades back, of late we started working on a quality of life and the aesthetic. So that's, as Dr. Nitin has already told, it has a good psychological impact of a person. So the two major challenges what I see when I get any kind of a patient for maxillofacial reconstruction, that is a complex 3D architect. There is no straightforward geometry. There is no triangle, there is no circle that we can just draw it and fix the PSIs or any other of the tissue. We have eyes, we have ear, we have nose, plus the muscles, the mucosa, the skin. Very complex architectures, right from the histological up to a functional. The key concept, what I believe when we decide to do any kind of a maxillofacial reconstruction, try to restore the same tissue as it was being lost from the maxillofacial region. And second thing, when you think of geometry or a structure, so the hard tissue reconstruction is a primary to get a proper form or a platform for that soft tissue to hold it. And of course, we have a sub-units, that is eyes, complex thing. The first thing we thought, why not to get a soft tissue? We did a tissue expansion in the shoulder area, took that entire tissue towards the face and reconstruct the soft tissue. Later on, we think of doing a bony reconstructions. And of course, the PSI, the autologous bone graft. That is the gold standard. Everybody knows about it. I don't want to go in detail about that. Then, with the advent of new technologies, that is the 3D printing. So everybody knows what is 3D printing. It is additive manufacturing where we use multiple materials, synthetic to now natural, which is called a bioprinting technology. With really agree with Dr. Nitin Bola sir, we should not think of PSI if it is crossing the midline to one side to another, because the most critical area to treat in the PSI is the mandibular anterior region. We don't have enough of soft tissue. So this is our case, and this is 5 years follow-up, and the patient is still doing good. And this is how the process is. And I don't believe in the cement retain or something prosthesis and the studs coming out of the soft tissue in the initial stage. We always believe in a multi-unit transbuccal kind of an abutment for the maxillofacial dental rehabilitation. This is again, for the cartilage, we don't require exactly the chondrocyte, but just mesenchymal cells as well as the adipose tissue stem cells can be used for the chondrocyte regeneration. So for the cartilage in the market. So we try to obtain those things, and we
surgery, stepping stones. Welcome, sir.
Honor to be standing here speaking after so many luminaries and luminaries present before me, particularly Dr. Paul Sambro, whom I follow, and Brigadier Roy Chaudhary. So far we have had brilliant presentations on bioprinting, robotic surgery. Today my talk is directed to those amongst us who are considering the switch from conventional surgery or adopting computer-aided surgery in their practice. Technology is all around us. You pick your smartphone. It is loaded with tech like LiDAR per 100x. What I mean to say is that each case starts with a case chief complaint. We follow it up with clinical evaluation, imaging, perform the surgery meticulously. In spite of that, one may have suboptimal outcomes. This is where technology can help us. So, computer-aided surgery or computer-assisted surgery just refers to the adoption of computer technology in all these aspects of surgical management. Technology. How do we go about it? Sometimes we are stuck at a basic level in anatomical structures. This is the procedure with patient-specific implants is already told many a time. The operation, we have utilized mirroring to generate the computer a custom implant or a patient-specific implant. Another case, again referred for reconstruction of a part of the mandible. He had suffered a gunshot wound earlier. Some form of reconstruction was carried out, but we don't have the details of the reconstruction. Anyway, the reconstruct had failed, and there were draining sinuses extraorally and intraorally. The patient had severe trismus, and the occlusion was delayed. We have to correct the angulation of the proximal segment. So the proximal segments, the intercondylar width, they have to be matched. These are things, these are the finer nuances of going for a patient-specific implant. Many a time these things may miss, and the surgery may, the surgical result may be suboptimal. And the next progression in the computer-aided surgery ladder is composite models. Composite models, this is relevant to this. Composite models are basically a model which is generated by a mixture of 2 or more images. In this case, we have the image of a mandible that we have corrected, we have mirrored. Now part of the mandible on the affected side is intact, and we intend using that the existing mandibular fragment also. So this has to be incorporated into the mirrored image. Thus, marrying of both the images or superimposition of both the images is called composite modeling. Composite modeling may be not only 2 CT images. You can marry up. You got to marry up the like anatomical points. For say, if I give an example of you do a Ceph tracing, you want to do serial Ceph tracing, we generally match certain anatomical points. Generally, the sella turcica is used. In this also, we have to match it, and that is called registration. I'm just introducing the terms which are used in computer-aided surgery. So registration, again, there are different, again, we have cutting guides and a custom temporomandibular joint. So these are the progression in, so intervention points in computer-aided surgery. So far what I've shown you is you have some physical construct in your hands. It could be a model, it could be, when I started off to cut down the costs, I took the pains of doing much of the planning myself. Like sir had already told of different softwares. There are softwares available for segmentation like Invasalius, OCDX. These are freely available, free to download software. And it requires a little bit of training on that. And you can carry out your own segmentation. If you want to really cut down costs, you are hard pressed for finances, you can actually do those, you can utilize those free to use software. So that can be used.
Thank you so much. Thank you.
Thank you.
Very good presentation, Colonel Sudhir. Thank you.
Yes, sir. Thank you.
Dr. Ghosh, sir.
Yes. ठीक सेंटर में लो उसको. Yes, sir.
Dr. Nijit Bola, sir.
ठीक.
Can somebody connect?
Yes, sir.
Colonel Dr. S. Sudhit, sir.
Thanks, sir. मुझे नहीं पता था. Yes, sir. Thank you. Yes, sir.
Now I request Dr. Sushmita Rajmohan ma'am to please give certificates to our chairperson.
Yes, sir. Yes, ma'am.
I'm just giving an analogy to say that you know how word spread, see how it spread, that you left a ABMSS fellowship, Kunjan got to know you got to know. So based on her decision,
All three. He was like Ankit last year. Ankit was also in
indicated for treatment of juvenile recurrent parotitis, as well as I said, recurrent parotitis due to obstructions. Catheter, I inject 3 cc's, the syringe in its place. I walk out, they do the X-ray immediately, and I can see a very good anatomic description of the gland. 99 metastable technetium per technique. Not very defined, but you can see here. There is a description of something called the sodium-potassium 2 chloride contrast. So technetium will compete with chloride because technetium is a member of the seventh periodic group in the table of elements. It's a pseudo halide and will mimic aspect of the salivary gland. The problem is when you give radioactive iodine to a patient that has thyroid cancer, the outcome will be a radioactive induced obstruction due to stricture of the duct, and the patient will have recurrent obstruction.
Surgical management of mandibular condylar fractures at different levels. So the topic will be content about introduction, anatomical consideration, existing approaches, classification of a fracture, technique what are available, case profiles, achievement and limitations of my technique. So coming to a brief introduction, we all know about a mandibular condylar fracture. It's been associated with the other parts of mandibular fracture, and there are several approaches like extraoral, intraoral, submandibular. Several approaches are there, but commonly now extraoral approaches having a better visualization as well as they facilitate a fracture reduction and fixation over there. So what all the worry over this in the topic, like why I have been taken up this topic is there are the prevalence of facial nerve injury as well as we are being worrying about the content. One is a facial nerve and another thing is internal maxillary artery. So these two things only we are being worried about in this approach when we go for a condylar fracture fixation, and later on we will be seeing a postoperative image for a subplatysmal also we can go for it based on your dissection where it's going in. So then once you go for a subfacial dissection, you will be seeing the posterior of a ramus of the mandible. So blunt dissection has been made and you go for a submesenteric
osteomyelitic changes, because it is good in picking up early changes in marrow when your bone scans are tricky and then it is ambiguous. So you can offer MRI and CT for cases in which it is gone beyond primary spaces, and then you can rely on physical examination, which is the time-tested method. Then moving on to the next modality, which is the USG. USG is the main problem with USG is more subjective. What I tried to say is it is more dependent on the MRI, so you can rely on USG. USG not only helps in diagnosis, but also nowadays we have USG guided catheter drainages, which is more common in abdomen and thorax, but still for some deep neck infections where extensive exploration can be avoided, you can trust on USG. And another important area where we all should be trained, because USG helps us in achieving pain control for cases require surgical intervention. Again, the same clinical classification holds good for this. We need to know in which category the patient present to us, whether the patient is in inoculation stage or an abscess stage or a cellulitis or a resolution stage. Based on the set of clinical features, we can classify them, and then for a cellulitis stage, we can get away with surgical decompression, and for a initial cellulitis stage, if the patient immune system is good, we can get away only with antibiotic. But surgical management still is the mainstay of treatment. And then if all this fail, again, as our last speaker pointed out, we have to look for any of these factors. If there is a protective mechanism, until 1 or 2 degrees, we never used to give any antipyretics, and because that helps in the temperature enhanced phagocytic activity. So that is a useful protective mechanism. Never interventional USG technician, you can. It's good that you have some extraoral blocks, guided drainage as possible with a good USG. And then not always the infections, names of the bacteria. For example, few literature addresses them as bacteroids and few address them as Prevotella and Porphyria. Molecular analysis, actually molecular analysis has shifted the concept from single pathogen to community as a pathogen, because many of the so-called uncultivable or uncultured culturable bacteria have been identified in near future. So that has increased the spectrum of microorganisms, and so it has changed from single pathogen to community as a pathogen. So moving to microbiological study, the first generation is the old one. What we still do is culture method, and we have moved on to molecular detection method, species-specific PCRs, and then a broad-range PCRs followed. Now, there are certain organisms which will take 20 to 30 days for culturing them. So that much long time would be quite costly if you are dealing with a severe maxillofacial infection. Again, identification is quite fast and then easy in a molecular method. Then role of corticosteroids is useful. What do they achieve by doing quorum sensing is they actually regulates or they potentiates the bacteria. They produce secondary metabolites and then they help as well as immune mechanisms. So quorum sensing can influence in a positive way by which they can form symbiotic bacteria, or they can influence or increase the pathogenicity. Because of quorum sensing, they are resistant to many antimicrobial agents, and then they reduce the permeability of the outer membrane, and then they have a multi-drug efflux pump, so which
what regulation depends upon the level of fracture, possibility of displacement, access, and the surgeon's experience. So the challenges it has been encountered in specialization includes high level. This procedure is technically demanding, but it requires a steep learning curve, and initially a longer operating time can be expected. The post-operative functional regimens were MMF this first incision, followed by incision similar to that of a sagittal spread osteotomy, and then exposure of the fracture site with adequate stripping of the temporalis muscle and masseter muscle, and then access using specialized instruments.
Thank the Almighty for keeping us safe through the pandemic so that we are meeting up again and we are able to operate and work and serve our patients. I'm also thankful to the organizers for having invited me to this wonderful event. Well, malignant tumors of the salivary glands are rare tumors. They have multiple histologies, they have diverse clinical presentations and biological behaviors. They are so rare that you will rarely find any single institution, multiple multi-center studies across the globe which have been conducted, like this study which was published about 6 months back, and almost 5,800 patients were studied to just give an idea of how the tumors are distributed, what is the demography and the epidemiology of these cancers. So in this study they found that 35% of all salivary gland tumors were carcinoma, X-pleomorphic adenoma, and acinic cell carcinoma. These 5 were the commonest occurring malignant tumors of the glands. And as far as the site distribution is concerned, the minor salivary glands are the commonest sites, making for about 50% of all the malignant tumors of salivary glands, followed by parotid, then submandibular and sublingual. And they have also mentioned their analysis based on low aggression and high aggression, and this matches with what we just saw in that analysis of 5,800 patients. The commonest age group is 40 to 60 years of age, female preponderance. There is a slight female. About the commonest malignancy of the salivary glands, that's the mucoepidermoid carcinoma. Histologically, it has been divided into 3 different grades: low grade, intermediate grade and high grade, and depending upon the grade of the tumor, the survival of the patient and the overall outcome of your treatment is a lot dependent on % in high grade tumors. So it is extremely important to understand what grade of the tumor you are dealing with when you are operating or when you are treating on a patient. Lymph node metastases occur in almost 30 to 50% of high grade tumors, and this is the stage wise disease-free survival for these patients.
And then based on that you find out. Okay, so I know being in your situation is very difficult because you don't know. So it's all right. You can try.
Was it last year? Bangalore session I was not able to attend. That was in 2019. But we also had an online conference. Many of us would have been part of it, and if you missed it probably. So, Tarunjit, session, and Vivek, thank you for coming. Nehal, thanks. Thank you. Yes, so I think without further ado, we can just start.
We had a very to be here. It's really a pleasure, and I'm really looking forward to getting to know all of you. And I think it would be great to sort of create global awareness of and also work together. And when I was at the seminar yesterday, there were so many women. I was so impressed, and I think we can learn a lot from you in the United States. It sounds like. So what I was trying to do is. I'm trying to look at really at the topic is why do we have organization here? There are only very few women who participate at that level. If you look at academic careers, and these are these are the numbers from the United States. We start with about 50% or now even 60% of women in dental schools, and I'm sure it's the same here. We actually talk about the feminization of dentistry, and I completely agree with you guys, dental schools, but they're not really progressing through to leadership positions. And what is the reason? I think one of the reasons, and I think maybe the women among you can relate to that, that we do not feel part of the leadership organization very much. When I sort of send out an application, or many of us feel, well, I don't know whether I can do this job, they are more hesitant. Yeah, and they don't feel like they can make a difference, don't feel welcome in these positions very often. So then what we have to do, or what I do what's called active recruiting. I call all my female friends and say, you need to apply. Yeah, and then they have all kinds of, all kinds of concerns, I don't have. We probably don't have that many reasons, just from a societal, social point of view. First of all, we have the human capital. Development opportunities. I'm sure, if you are in a very good school, you have a lot of development opportunities. I think what is very important is networking. And as women, we are very good in networking in our families, but we are not very good in networking and advertising for ourselves in our professional lives. Men are really much better. We need to learn from them.
To be honest, don't get this time. Only modest, okay. So even if you're at 8 also is good.
Somebody straight local and do you know good grade? So what you do is within the company make a visit.
ಅವರಿಗೆ ಕರೆಸು ಸರ್ವಿಸ್ ಮಾಡಿ then 4 or 10 I'll call one for and just talk for 3 minutes and get general opinion ತಗೊಂಡು you can go there.
Silk thread, approximation of the lower border of the mandible and the lingual cortex was assessed based on the radiographs like OPG and occlusal radiograph. Hardware failure was assessed post-operatively after 3 months. Coming to the surgical procedure, fracture was addressed through the existing chin lactation or through the mandibular degloving incision. The fracture site was exposed and the neurovascular bundle was identified and skeletonized. MMF was released and a complete reduction of the fracture graphic image depicts the image of a 3D plate placement and the radiograph. All the qualitative data obtained was analyzed using the SPSS version 26.0.
Now, every patient presenting, since the audience I can see more of postgraduate students, when a patient presents with fever, submental and submental swelling and tenderness, oral signs of infection, swelling of the floor of the mouth, elevation, tongue, tenderness of the involved teeth, the space, serosangulars infiltrate with or without pus, involved connective tissue, fascia and muscle, but not glandular structures, spread is by continuity rather than lymphatics. Now coming to the treatment goals, sufficient airway management, early aggressive antibiotic therapy, incision and drainage, adequate nutrition and hydration, as most of these patients will be dehydrated. Now for the post-graduation, so it is initially starting with the consultation. On the consultation, a history is very important, documentation is very important. In that documentation, it is always better to take the consent of the patient. It is a very important thing, consent, because I will show you one of the cases which we recorded, an airway examination, assess for the complete blood count, then management, oxygenation, fluids, rehydration, and yes, the source of infection has to be addressed, and pus examination, check for microbial culture, antibiotic sensitivity, airway management, incision, tooth extraction, hospitalization, and I also said high-risk consent. Now, here is a case of a man, a 31-year-old man. I just put 3 slides of his. He presented with the swelling, 5 days. His presentation was 5 days with swelling and pain. But when I took up the history, we got to know that and there also management was done, but it was of no use. Then he came to the preauricular region on the left side, and post-auricularly the swelling had extended. There was, and also he had a history of, he was a known alcoholic and liver disease patient, so he was an immunocompromised also in that way. Now, the management part, we definitely managed the airway. We did a tracheostomy and followed by incision and drainage. This patient, after 7 days, he develops fever. And later his condition worsened. And you can see we have pus was drained, and we can see the necrotizing fasciitis or orocutaneous fistula is there, and also you can get rupture. This patient presented with almost all the complications you can get. Now this is a case 2 presentation. This lady had presented 2 days after she developed this, and we had done a nasal intubation and she had recovered very well. Sorts of features of a classical Ludwig's angina, but here what I want to say is the presentation. One of my speakers had said the presentation and the timing of presentation and the management is very important in Ludwig's angina. This case is important as it illustrates the need to recognize the early treatment of disease. I have just put it in a nutshell because my topic is not on airway management in Ludwig's angina, but just the potentialities. So conservative management, tracheostomy, endotracheal intubation, the choice has to be taken appropriately. Routine orotracheal intubation may be complicated. It can result in potentially fatal complications like necrotizing metastalsis and sepsis. Mortality associated to necrotizing metastalsis can reach 40%. The end result of all this is systemic manifestation leading to septic shock and need for admission in the ICU. The treatment plan for each patient should be based on the phase of infection and associated condition at the time of presentation. So clinical signs and symptoms should be assessed, and conclusion, early diagnosis and prompt management, antibiotic therapy, early surgical intervention is required to provide a higher control of the patient's health. Diagnostic delay. The speakers also mentioned diagnostic delay or latent or inappropriate drainage of the infected compartments are judged to be the main cause of death. Now here, what are the important clinical questions we have to keep in mind? When the patient presents, is this really Ludwig's angina? You have to look into the clinical signs and symptoms. Is my patient's airway compromised? And the treatment plan has to be looked into. So these are the references. My acknowledgements are to my guide, my teacher, Dr. Rajendra Prasad, Dr. Sharma, and my friends, Dr. Vadish Bhatt, Dr. Amit, and here is...
Nice presentation. Can we call Dr. Zainab Chaudhary?
I'll be speaking on mucormycosis post-COVID, the surge in the cases and the challenges we faced in treating them. So COVID-19 during second wave in 2021 caused a devastating chaos in India. Our country not only encountered inadequacy in health infrastructure but also faced shortage of hospital beds, vaccines and oxygen supplies. An additional burden to this challenging situation was the unprecedented surge of mucormycosis in COVID-19 patients. Mucormycosis is an acute angioinvasive necrotizing tissue infection which is caused by any of several species of fungi that are classified in the order Mucorales of the class Zygomycetes, including Rhizopus mucor. This deep fungal infection is also misleadingly known as black fungus due to its resemblance with the Dematiaceous fungi. Dematiaceous fungi are nothing, they are the group of mucormycosis is an opportunistic infection which affects the lung, skin, rhinocerebral area in the central nervous system. It can be a fatal complication of severe COVID-19 cases, particularly in immunocompromised and uncontrolled diabetic patients. We saw the surge in the incidence in COVID patients particularly because of the immunocompromised state, giving rise to the opportunistic infections. Also because of the hypoxic conditions present at that time, the high glucose levels which were seen in uncontrolled diabetes mellitus, in newly onset hyperglycemia, steroid onset induced hyperglycemia, which led to fungal infection. There was a surge of the mortality rate from 50% in the pre-COVID time to the 85% in the post-COVID time. The reason may be because of the crowded hospitals, because of the unavailability of health workers, or because of the shortage of drugs. So what observation did we find in the pre-COVID time of mucormycosis and from the post-COVID time? There was definitely an increase in the incidence. Not only that, it was of faster onset and progress, was occurring in young patients, was rapidly and were on steroids. So in addition to whatever investigations we were going for the fungal infection, we had to go for another investigations like inflammatory markers and the HRCT. What are the potential risk factors, diseases or the previous parenchymal lung damage which has occurred in these COVID patients? Also the environment was affecting, the hot and humid conditions were leading to the increased fungal growth. Plus inappropriate use of antibiotics, it interrupted with the normal cyanonasal microbes. So what the challenges which we faced during...
And we created a total 4 modules of based on human anatomy model. These 3D finite elements were converted. We see the structural deformity as well as von Wieser stress in this region, in the transition zone. If von Wieser stress increases, the chances of fracture of plate increases. So lesser the von Wieser stress, the better the stability of that fixation and better osteosynthesis and more rigid fixation which we are going to achieve. Grade 2 titanium and which is having a Zen's holder of 100-70 and it is being manufactured by designed by us, manufactured by Optimax. These are the models which was constructed. The models were isotropic, homogeneous and linearly elastic, and we can see that the very well adaptation.
Sometimes they're not enough. So what you need to do is actually see it in real time, which is what the camera does. Once you introduce it, you see actually what is happening. The scans might lie. So that's one huge advantage. And I think Dr. Helman mentioned where they use cyanography. So narrowing can be done by balloons, which I will show in the video. But you can also use different sizes of scopes to go through strictures and widen any narrowing. And whether it's useful or not, you can instill some medication introductively. Naturally, everything isn't rosy, so there are some issues. However minimally invasive you want to say it is, it's still invasive. You still might need to make a cut somewhere. And there's a learning curve, which I like to use this image because it's sort of similar to a Dunning-Kruger effect, where initially you think you overestimate your abilities, then it sort of comes crashing down a little bit, but eventually you sort of plateau and are reasonably successful over time. But like I said, it does take a lot of time. You already had a look at all the equipment, you need only those specific. It might be about 3 or 4 mm. Also remember that the stones can move, so it can move posteriorly, so just because you think it is there based on the scan, you might find nothing. And the minute you make a cut, you tend to lose depth of ductal opening. You introduce an appropriate size cyanidoscope. Okay, so once you've introduced it, this is what the duct looks like. This is a submandibular duct. Normally looks a bit pinkish. You can see some vascular markings, and as often described, you can see it's a bit tortuous. So the idea is to try and navigate through the entire duct. Okay, you can see the branching there.
Remember what
It depends on the onus is on you. We offer training in the specialty practice.
Go ahead. Janmesh?
Now you are free.
It should be done immediately after the case. It should be complete.
That's what we do.
Don't do anything. Because there are a few things to discuss.
I don't have to find a camera. There is a fixed source of income, and so I want to get my hands on. I know I'm getting surgery. I should relocate a man never thinks that I will have openly for 8 together. I have some men who have that kind of job that I have, but that percentage is long 8-9 hours and operate. So
that question wouldn't have been asked to me.
That was asked to me.
No, she said that could she be allowed to It's a question to be asked. It's a question that wouldn't asked to me.
One word segment. Yeah, we're done. Yeah, that's what we're trying to do. So great. Just show me a
Introduction. Angle fractures account to the most commonly infected fractures. Incidence being reported in literature is 11 to 14%. Owing to the presence of third molar in the line of fracture, hygiene maintained by the patient post-operatively, and communication of these fractures with the external implant removal and surgical site infection post-operatively in angle cases. Objective was to eliminate and reduce the rate of infection. So a total of 20 patients were operated from the year 2020. 5 of our patients came up with surgical site infection, owing to which they needed an implant removal.
Mechanisms were cultivated and were sent for culture and sensitivity, and multiple space involvement had surgical drainage. Now going back to this question, I would like to put a question to the panelists, starting with Dr. Akshit.
That is there a role for conservative management in maxillofacial infections? I feel there is a role, because if you look at the pre-antibiotic era, most of the infections had a high mortality rate, which was nearly around 85 to 100%. But post the usage of broad spectrum antibiotics, the introduction of them, the mortality of infections have come down to up to 5%. So what it usually says is that the usual dictum that we have, that the aggressive surgical intervention of having an incision and drainage need not be advocated in all the cases. Okay, so we have the common saying that goes with aggressive surgery, that do not let the sun set on the pus. Need not be the case now, because in some select cases, like you have very mild cellulitis, or you have very non-discrete abscess formations, you can of course go for antibiotic only to subside the infection.
Dr. Radha, could you throw some light on this?
I would just add on to what Dr. Akshit's already said. I would say that primary spaces, by which we would understand it's either a palatal space or vestibular space infections. If you see them in early cases, say it's up to a 3-day-old swelling, a cellulitis stage which hasn't progressed on to abscess, then pretty much safely we can say, with empirical coverage of antibiotics and plus or minus, if it's amenable to treatment by RCT in odontogenic infections, you can treat them conservatively. Beyond a point, as surgeons, we would all be very eager on going aggressively on it, and that should be the course of it if it's a 5-day and beyond, and if we see infections which are in the mandibular spaces or below it,
Number of patients they had treated, they have mentioned whether the incision drainage or removal of the cause of the infection was performed, description of patients, evolution according to intervention performed, and report of clinical follow-up of patients involving alveolitis, periodontitis, and infected odontogenic cysts. Now, in this particular article, they came to a conclusion that only when the immune system has been compromised and the defenses are unable to control the infections, then the antibiotic of choice should be administered. Typical signs like edema, dysphagia, trismus, tachycardia, dyspnea, general malaise, fever are again clear-cut signs of use of antibiotics. Removal of cause, 98% of the cases resolved in 2 to 3 days. Now going back to the first page, I would ask the panelists 3 significant questions. Which antibiotics would they prefer to use? Which is the drug of choice? And second, third is how long they will be used. Again, starting with Dr. Akshay.
The gram-positive cocci or the gram-positive aerobes together with the anaerobes. Okay, so you will have predominantly streptococci with alpha-hemolytic streptococcus, which are the anaerobes. And because of that, the antibiotic that you need to administer is to be such that you have to target the aerobes as well as the anaerobes. So the best would be, according to me, augmentin together with metronidazole, or and mostly in such cases, what is seen is that 20% of these cases tend to develop resistance to this antibiotic. So you have other options like cephalosporins or fluoroquinolones, which can also be used for the same.
Dr. Radha?
There. So as the patient comes, probably the patient will come with either in a cellulitis stage or in an abscess stage, right? So in a cellulitis stage, we can at least aspirate and send it for culture rather than just giving the antibiotics. And in the other case, like in abscess, we can definitely start with IV antibiotics, and accordingly we'll do the IND and send it for culture and can start the antibiotics.
Dr. Swapna?
Hello? I think we've covered most of it. The only thing I would like to add is how long should antibiotics be administered? Now, I think we've all been, most of the time, not really been relying on tests to do it, but most of the time in ICU settings, people rely on CRP and PL levels to determine when to stop an antibiotic, and that would be a good practice if we start adopting it in a maxillofacial practice.
Now I have a question. Suppose
I think that it's completely natural. When you don't have an option and you're trying to preserve the nerve in low-grade tumors, I think it has significant room in order to do it, because you don't have any other option unless you impede significantly the quality of life of the patient.
So Rahul, no T20 only test cricket?
So the important point only for Wardens is what you would recommend extracapsular dissection. I think extracapsular dissection is like, I would say, coronectomy. When would you teach a coronectomy? Is when you would have done a huge amount of third molar removals, and then you would think of doing a coronectomy. I would feel it is safer to do a partial superficial parodonticus. This is very difficult to treat, and an extracapsular and a partial superficial parodonticus is extremely safe.
But Vijay, isn't it a part of an evolution of a technique, just a means to an end? Perhaps somebody who's very confident in his hands.
So there are few studies which have reported a good outcome.
I think that brings us back to Dr. Hellman's point. I'm generally brave, so I'll be brave enough to disagree with him. And I wonder why, Dr. Hellman, we cannot do an extracapsular dissection if we are confident of leaving one layer of core capsule on a pleomorphic adenoma. Why would you be
the tail of the parotid gland? I am already on the potential cyst and a lot of other complications that they really, or a salivary fistula, they really don't need. So why not to do the proper treatment?
Yes, Rahul.
I would be rather worried if I'm doing an extracapsular dissection for a pleomorphic adenoma rather than any other tumor, like Wardens tumor, as he said, because we.
It's really important is persistence, and then also having your own values. I think you really want to be partners with. Why it's so wonderful that so many men are here. But it's not, we need to work together. I mean, this is how we all can be much better in the future. So next one, who is the next group? Yes.
Man asserts something that is considered a good trait, but when a woman says the same thing, then it is considered that she is an aggressive woman. Correct. But I have no solution to this. I think I expect solution from one of you. That's I would choose to continue being assertive.
Males cannot take leadership from a female. And I am facing that from almost 10 to 12 years now, and I am continuously punching. That's the only way. There's no other way. That's the only way. And I'm still doing it.
As long as the few men don't get punched here today, it's okay.
All the discussions that went through is that social biases and cultural biases are there. And it's not going to go away in even in a generation or even 2 generations. And I think the change has to come from mothers and how they treat their children. I think that was already mentioned. And I think that really would be where the women should take it up from. And I don't think it's actually the men who, the fathers don't really put that kind of pressure on the children.
They adore their daughters.
And that would cause an airway compromise.
So this next question goes is
Simply
that
speaking, primary spaces, we don't need secondary spaces, we are suspecting, we do
yes,
a CT.
I agree with it, but one question I have is, at that point of time, will you intervene or will you advise CT scan? When you see the patient in distress?
Yes, if the patient is in distress, obviously you will intervene.
Okay.
And then probably
So you
send
would
the
do a
patient.
CT scan later on once
Yes,
the
send the
patient
patient later on.
Later on, because it will also give us an idea, is it the only site involved or if there is anything
multiple
beyond?
spaces are involved.
Yes.
So medical legal point of view also.
The role of CT also extends to CT guided drainage these days.
We will come to it, the next point would be that. So this basically also the medical legal point of view, we have this that we need to do a CT if required, definitely yes, as a documentation. Then the next thing is, the next question, the last question is, does CT image guided surgery have a role to play in maxillofacial infections? Again, 2 articles. They have given the first article by Cable et al. That with the 12 children with potential deep neck infections where the abscesses were drained by CT guided interventional guided surgery, CT scan, and even the endoscopic provided direct visualization of the cavity, and they were instituted antibiotics and discharged within 12 hours. This article by Delights showed that you can use ultrasound-guided transoral drainage in pediatric population to prevent any complications. So I would like to put to the question to the panelists, in today's age, does it have a role, CT image guided surgery in maxillofacial infection, draining them?
Definitely we need an interventional radiologist for it, right? So we are directly referring the case to the interventional radiologist rather than treating ourselves.
And also the cost, not every patient can afford it.
So it
But
is,
if the patient is affording, definitely it have a role.
so you would
And
definitely,
aesthetically also a lot of people do not want those scars, so it would be a little more aesthetically pleasing.
And it's safer too, because in deep spaces there are many vital structures.
so given a chance, you would refer the patient, I mean, you would
definitely.
definitely go for intervention and CT.
Basically in spaces
Okay.
below the hyoid bone.
Okay, I think we have come to the end of the discussion debate. Thank you so much, panelists, for taking part in this, and also thank the audience for a patient hearing. Thank you.
I will request our moderator,
Thank you.
Dr. Swapnil and Dr. Rakshit sir.
Yes. Thank you.
Thank you.
सामने देखते हुए
That place and got on the other side of the table, that's it. So there is no difference between you and us. It's just we are on this part of the table, you are on that part of the table. So we all have been like you during our study periods. But what was lacking was a guidance which would help people to go forward with. So that's what we thought we should be speaking on how to become a good maxillofacial surgeon. There's no strict recipe to it. And the best thing about this to join me is Mr. Chetan Katre. He's from UK. Our own person who has been a graduate and postgraduate from Davangere, and now he's a consultant in London. So he has traveled. So the difference between a teacher and a mentor is a teacher will teach you what to do. A mentor, like there are 10 flaps for cheek reconstruction in the book. A mentor will tell you which way to go. Because a mentor knows the way, goes the way, and then shows the way. So we have an excellent mentor in form of Mr. Chetan Katre. They write Mr. to all the surgeons. Surgeons, they don't like doctors in UK. They like Mr. So Mr. Chetan Katre. Chetan, please come and join me.
Thank you, Nitin. What can I say? First of all, thanks to Nitin and thanks to the organizers for giving me an opportunity and requesting me to come and speak over in the conference. I've been to quite a few national conferences. It's a privilege, it's an honor. And yeah, I think Nitin's given a very glorifying introduction for me. Nitin doesn't need introduction, isn't it? Everybody knows Nitin. In fact, when you're walking with Nitin, you just have to walk about 10 meters. And someone else wants to take a picture, and then you again walk about 2 yards, and then someone else wants to take a picture with Dr. Nitin Bhola. He's a very busy man. I think we all know his achievements. He's a very humble person, and I understand that he graduated in 2002 as a dentist, and then did his MBS in 2006, and then rest is history. He's a workaholic. He's a director of a 100-bedded specialty hospital. I don't know how he manages. He sings, he writes, and he's a multi-talented man. He doesn't need any introduction, and he's a workaholic. And I always used to say to Nitin, you know what? If you didn't come to dentistry or Max Fax or Head and Neck, you probably would be in Bollywood by now. A big film star or a hero. So that's Dr. Bhola for you. I think one of the, and I'm so glad that, he requested me to come and do this joint talk, because surgery is not only about operating. people think, oh, if you can operate, you're a surgeon. No, it is much bigger than that. So myself and Dr. Bola has combined the presentation. I didn't put my picture because putting a picture besides Nitin's picture, unless and until you are, Shah Rukh Khan, or even they can't compete. So
I need to hide.
So let's start with the topic. I'm going to try and summarize and say and express what is required, or what are the characteristics, what are the traits of not only maxillofacial surgeon or any surgeon, any surgical specialties, and some anecdotes here and there. So it'll keep you, it's 4 o'clock in a nice lunch. Probably you're almost at the finishing time of the conference. So let's start the bit of my biodata. That's fine, which Dr. Bola has already mentioned to you. I graduated from Davangere, 1987 batch. Did my MDS, worked for 2 years with Dr. Kishore Nayak, who's one of the legends in this field in India. Then went to UK, worked as an SHO, did my medicine, MRCS, FRCS, statutory exams, and so it is achievable. And if I can do it, all of you can do it. Whoever wants to do it, always remember.
Turning out into yet another boring keynote session. So if you can make it interactive, if you have any doubts, anything to ask, you can please raise your hand and we will be very happy to answer it. So let's have interactive and not a boring keynote session. Chetan, to you.
Yeah, thank you. So Dr. Bola I'm happy with that actually. It would have been a difficult one to catch up with his act otherwise. So how do you find the training program in India? Probably Nitin, you can elaborate a little bit on this from your perspective.
Yeah, when I see him, they have a rigorous training program whereby a maxillofacial surgeon has to do a med school, dent school, and then become a maxillofacial surgeon. And what I see personally in India is it's a short program of 3 years, and there's a huge leap from a background of dentistry to you're wanting to do something which was not taught to you. You will accept this. We have been reading books like books for pathology for dental students, pathology for pharmacology for dental students, all good cuts. Now there's a huge leap. You have to make a shift from that dental background to something where you are competing with an MCH Anko guy. A plastics marked by sporadic excellences in this country because the training structure is not uniform. Out of all these people sitting here, including all of us, we never have been trained adequately or equally. If a surgeon, like a product passes out, he knows this amount of competencies definitely. That is something lacking in this space. So apart from that, yes, we are huge clinical material. So the hands-on is very good with the Indian people.
Answered yes to most of these, then the OMFS career is the right choice for you. And are trained and not born, or they're born? Quite a few I've heard, they said, oh, you know what, I'm a born surgeon.
That sounds good, but in reality, it is nothing like a born surgeon. They might have an inclination, or you didn't know you were going to be in dentistry. You were reading Ignatius Rock, Metamorphic Rock in 6th standards. LCM, UCM. We didn't know where we were going. We are not born.
Class 2 doing a neck facelift with very minimal manipulation of the platysma or any removal of the fat. But when you start getting into Class 3 where there's fat accumulation, face and or neck lift procedure. This shows you a mini lift. So in a patient like this, I've done a facelift, a formal face and neck lift maybe 5 years ago. And now I'm coming back and doing a mini lift. And that's all I do with the mini lift. A very minimal dissection. It's almost like you buy a car and every year you get the oil changed, right? This is like an oil change every 5 years. Just a small tuck to kind of maintain that area.
Just like an orthodontic, you in any specific areas that you might need, nasal or ocular or perioral. Now, let's talk about the operative technique for facelifting, a little bit about pertinent surgical anatomy, a detailed sequence of surgery, and then the dressings. And I'm going to go very, very briefly on this, mainly for the trainees, for those of you in the audience. How many in the audience do facelifts? Well, that's why you're here, right? He's going to start doing them. A few of you maybe do some. Facial muscles, the SMAS, the seventh nerve, and then the great auricular nerve. The muscles, basically 5 groups: the perioral, the perinasal, periorbital, the auricular, and the scalp. What I want you to remember is all of these are ensheathed by a sheath that is deep to the subcutaneous fat. It's densely adherent but separate from the parotid fascia. It's in continuity with the posterior part of the frontalis. I miss. And again, you know, it's what comes first, the chicken or the egg. I don't really know how I would do cosmetic surgery effectively without my background in oncology, doing parotidectomies and things like that. I also don't know how I would do aesthetic surgery effectively without my experience in oncology. Maybe I'm just an enigma, but one actually helps just for the most part. I'm not saying it's bad and they should never do it. I'm just saying the SMAS in the scalp is the same as the galea, and the facial nerve has a wide variation in anatomy. It innervates the muscles from the deep aspect. That's why when you start seeing facial muscles and you're doing a parotidectomy, anastomotic associated branches with them. So you cut one of those branches, there's not going to be anastomotic transfer of motor function from another branch, you know. And also they're the most superficial branch. The marginal mandibular most superficial as it crosses the mandible. So it's fairly superficial in that location, as you can see here. So localizing those 2 nerves and understanding them. But indeed, those 2 nerves are not the 2 most commonly injured. They're the 2 most vulnerable, and if some that they get cut, problematic. But the one that's most commonly injured with the
Oh, you're the, oh shit, okay. Time is up then. Because we had a presentation.
It's an hour.
I don't know. Yes.
No, it was an hour. It's a half hour.
It started in 40 minutes.
Okay, all right. Okay.
Because I have a presentation to make. I can speak if you want.
Anyway, for the trainees, do the easiest, for the consultants, do the easiest part of the operation yourself, leave the most difficult to the trainees, the rest is a fellow. Never offer to adjust the light in the operating room, you will never do it right, so don't do that. Okay, the best surgical sense is your intuition. Academic surgeons talk more, operate less. 2 words to control the bleeding. The first in the operating room and the second in the middle of the night. The rules of 2, when you hear a surgeon telling about the numbers cases performed, divide it by 2 because we exaggerate. And when they tell about the complications, multiply it by 2. A surgeon is sometimes right, sometimes wrong, but never uncertain. Good surgeons know how to operate. This is serious stuff. The better ones, when to operate. And the best ones, when not to operate.
Points. These are
our friends.
This has nothing to do with my presentation, but that is distraction. So anything distracting your target means dilutes it. So you should not have distractions in life. I just put it because I don't want you to sleep. So there are verticals of success: skill, academic knowledge, presentability, and the right opportunity. Skill without academic knowledge is butcher. Absence of one of them is a guarantee for failure. If you want to do good, you need to put an extraordinary effort in your life. So I don't want to do that. Our strength is the amount of work we have. Weaknesses is the kind of training we have. Threats, overlapping specialties in our area. But one answer to it is, if you can hold your fort correctly, if you are skilled, you have read well and deliver well, I am telling you, there is no problem. A plastic surgeon operates, with all due respect, I have huge amount of friendships with plastics and other specialties. There is no point fighting. First thing you understand, first point he made was statement. Only fools fight. Oh, they are plastic surgeons, they are demeaning us, the ENT surgeons are demeaning us. Learn. If they have something to offer, now there is a reversal of trend. Now, plastic surgeons, they come and standing on OT and they say, हमको इधर सिखा दो. तो मैं आंसर दे रहा था, तो सीरियस मॉनिटरिंग हो रहा है मेरा. उससे मैं हाथ मिला लूँगा, मैं उसे हाथ मिला के देख लूँगा, इसका हाथ वार्म है, कोई स्वेटी नहीं है, थायराइड वायराइड नहीं है. धीरे से उसके पल्स दांत लगा लूँ, कैसे चल रहा है, आपको कोई बीमारी है, कोई तकलीफ हो रही है, पल्स देख लूँगा उसका, छाती देख लूँगा, उसका रेस्पिरेटरी सिस्टम समझ में आएगा. I would take the same time which you took to take a mouth mirror, put into his mouth without talking to him. The patient is judging. He will judge two doctors, you know. One who did that, and he will have an idea. ये अच्छा नहीं था जिस तरह. You have to पूछे नहीं. Just imagine you going to a clinic and somebody putting directly without asking you. I know not go to a doctor. I went to physiotherapy. I never went back to him again. I went to him. I said I have pain here. He said, अरे sir, आओ बैठो. राधिका, वो needling करते इसको, इन सर को. He took needles. I have pain here. I have pain in my wrist. She started needling in my arm. I don't know. So you have to be empathetic. Professional ethics when you talk or speak to the patient. Now these two gentlemen, I put their photographs. One is superstar of 60s and one is superstar of 220. What is the difference between them? Is because this man used to dance like a fool. और in current context, if you see this, ये क्या dance कर रहा था? Tiger Shroff का dance देखो. ये कैसा मोटा दिखता था, उसकी पैंट देखो कैसी है. But he was superstar then because he was relevant in that context. He is relevant in this context. So he was star then, he was star now. Both are relevant. What has changed? Is with time he has changed. People they realize that I need to make a body and I need to dance, I need to act, I need to have everything. I cannot be same. So if you want to be a good surgeon, you need to incorporate this. I don't believe in 3D printing. I don't believe in that. This is bullshit. People will not believe you if you are not constantly upgrading yourself. Anything that has to that doesn't mean every conference the concept should change. Be with a strong concept. But if there is something good to learn, if there is something good to tell me, I definitely pick up that point.
I completely agree.
What is it?
100% Nitin. You have to check your patients, not for your self-glorification. And if you don't change, you know, your outcomes will not be as good as someone others who's adapting more modern. And there's very little to change, but do change. You look in, you know, besides medicine, look in business nowadays. If you haven't changed with time, at least back home in UK, big shops in you know, sort of markets all gone because they didn't change to the online module.
Nokia was big. Let me tell you one thing. There's a huge opportunity for maxillary. This is the most thrilling specialty one can ever think of. Because what you do on face, if I and satisfaction, nothing to beat it.
Be proud of being a dentist. Be proud. Don't you know? That's fine. Be proud.
Satisfaction is one thing, you know. Not many people would have it. As a mobile seller, shop seller would not have satisfaction. He's selling mobile. I am doing a job which is giving me satisfaction because I'm treating people, making their lives better. So, lots of
that is the key of surgery. And there's a difference between knowledge and wisdom. I'll tell a small thing because even though you have taken up my time, I'm tempted to talk. As a teacher, since I think 2002, we were there together.
Yes. Take a break. Smile. Thank you. Thank you. Thank you.
Friends, please collect your certificates of this session.
Yes. Smile. Wait. One. Thank you. Thank you.